Major depressive disorder acts as a leading global cause of disability and suicide, representing a systemic physical breakdown far more severe than sadness. For over 50 years, the medical consensus relied on the monoamine hypothesis. This theory defined depression as a simple deficit of specific neurotransmitters, like serotonin or dopamine, floating in the brain's chemical soup. That theory drove the first wave of psychiatric pharmacology. Doctors deployed elemental treatments like lithium salts to try and replenish these missing chemical levels. Focusing strictly on managing these levels transformed the clinical goal into one of permanent maintenance. It socialized patients into the role of a deficient subject whose ability to function required a daily, lifelong biochemical scaffold. This chemical-first approach peaked with selective serotonin reuptake inhibitors, or SSRIs. These daily pills were designed to hold more serotonin in the brain's synapses. But there is a severe lag in this design. A patient in acute distress must often wait weeks for the medication to build up enough to produce any noticeable therapeutic effect. That delayed relief never arrives for about 1/3 of all patients. The medications outright fail, leaving millions trapped in a chronic state known as treatment-resistant depression. This failure rate indicated the underlying assumption was incomplete. Looking only at chemical levels blinded researchers to the physical damage occurring inside the brain itself. In the late 1990s, researchers at the National Institutes of Health began exploring neural pathways beyond the traditional monoamine focus. They were experimenting with ketamine, an off-patent dissociative anesthetic and stigmatized club drug. Initially, they were only using low doses of it to model the phenomenology of schizophrenia. But then they noticed a clinical anomaly. When administered to depressed patients via a sub-anesthetic intraocular drip, ketamine eliminated severe depressive symptoms and suicidal ideation in hours rather than weeks. These results demonstrated that the clinical timeline of the monoamine hypothesis was not a biological limit. Depression could be halted in hours, revealing a previously unknown pathway to rapid symptom remission. Ketamine ignores serotonin, targeting the brain's high-speed glutamatergic system. It heads for a cellular gateway called the NMDA receptor. By acting as an antagonist, it physically plugs and shuts down this channel, forcing a massive compensatory energy surge through a parallel pathway, the AMPA receptor. That secondary surge acts like biological fertilizer. It triggers synaptogenesis, the rapid regrowth of microscopic dendritic spines that chronic stress and depression had previously withered away. This circuit-centric model addresses the physical attrition of synaptic connections caused by chronic stress. Instead of daily management, research shifted toward repairing the underlying connectivity through episodic, rapid-acting neuroplastic repair. Generic racemic ketamine costs pennies to produce and has been off-patent for decades. Because it is unpatentable, no corporation would fund the expensive trials required to secure FDA approval for a psychiatric label. The drug also carries a DEA Schedule III classification, marking it with deep institutional stigma and a recognized potential for abuse and dependence. To monetize the molecule, the pharmaceutical industry engineered a workaround. They isolated a single patent-eligible mirror image of the drug, the S enantiomer, and packaged it as a proprietary nasal spray called Spravato. While Spravato secured FDA approval in 2019, it remains restricted. Patients face variable efficacy, exorbitant costs, and a mandatory multi-hour clinical observation period due to the risks of heavy dissociation. The rigid demands of drug regulation and the patent system forced a widely available, low-cost medical intervention into an expensive and heavily guarded proprietary package. To fill the gap left by these restrictions, hundreds of standalone, off-label IV ketamine clinics exploded across the country, operating outside traditional psychiatric pipelines. This created a divided medical landscape. Insurance providers frequently cover the expensive patented Spravato, but they deny coverage for the cheaper generic IV infusions because they lack that specific FDA label. Desperate patients are often left paying entirely out of pocket, pushing access into a regulatory gray zone of cash-only clinics and digital telehealth startups shipping oral ketamine directly to their homes. While ketamine demonstrated that the brain can rapidly heal its own circuitry, the drug remains caught in a healthcare system whose own structure is too rigid and profit-driven to deliver it equitably.